good morning, everyone. Thank you for joining us for the breakfast at UMHealth this beautiful Wednesday morning. I'm Liyana from Emergency Medicine Department, and I would like to introduce my dear friend and colleague, Dr. Nabeela binti Azmi, who has been an emergency physician since 2018. And she basically is currently part of the vaccination committee of UMMC, and she will be enlightening us on the talk that is entitled Thrombosis with Thrombocytopenia Syndrome Post-AstraZeneca COVID-19 Vaccination from the Perspective of Emergency Medicine. Basically, we will try to save about 10 minutes at the end of the talk to answer all your questions. Please fill it in the Q&A box. I now invite Dr. Nabeela to deliver her talk. Thank you.
Okay, thank you, Dr. Liyana, for the kind introduction. Today, my topic will be thrombosis with thrombocytopenia syndrome post-AstraZeneca COVID-19 vaccination from the emergency medicine perspective. Okay. So a little throwback, 6 February 2020, I was a co-speaker in this Wednesday morning symposium titled, Should We Worry About the Coronavirus Emerging from China? So basically the gist of the symposium was, well, to worry, but not too much. But next month, MCO starts, and I think we're still there, still in a pandemic, still wearing masks, and worse, a lot of death daily. So a little about the AstraZeneca vaccine in Malaysia. So even though the national vaccination program in Malaysia started in March 2021, it was only until early May that the AstraZeneca vaccination start. It is a non-replicating viral vector vaccine, so a little different from our Pfizer vaccine and also Sinovac vaccine. And registration was via opt-in. It was opt-in as there was just too many bad press regarding the risk of blood clots. So you see, when the UK and the Europe started their vaccination program, they kind of started with AstraZeneca. AstraZeneca was one of the first vaccine that was started to be given to them. So they had a lot of vaccinees coming with the blood clots, immune mediated. So by the time the vaccination program was to start in Malaysia, there were quite a bit of data regarding the thrombosis, just a little bit, but not too much. So, you know, when people don't know much about something, then the fear will come. Nevertheless, in the early May 2021, the first registration, 250,000 vaccine, it was taken up in 3 hours, and the second round of vaccine registration on the 26th of May, 1 million or 1.2 million of vaccines was taken up just in 1 hour. So you can see here, if you just Google Malaysia blood clot AstraZeneca, even though the title of the topic was something reassuring, you can see from the comments there, a lot of negative comments there saying that Kementerian Kesihatan is giving this to Malaysians but not to themselves and things like that. So this is, I like this image. It's a representative of just how much risk the AstraZeneca vaccine predisposed one to develop thrombosis. So if you can see there on the left side, for the AstraZeneca vaccine, it's just 0.0004%. So 1 in 250,000. In contrast to the very end on the right side, the end of the spectrum, if you do develop COVID, your risk of developing blood clots is 16.5%. I would like to point out here, however, that the etiology of the thrombosis in the AstraZeneca vaccine is not similar to the ones in birth control, smoking, COVID infection, and those that people develop post-surgery. However, being medical practitioners, low risk is not no risk. So all vaccinees receiving AstraZeneca vaccine have been properly counseled by our Ministry of Health about the symptoms that they have to look out for, symptoms that may be the first presentation of the thrombosis care clouding this vaccine. So you can see there sakit kepala. So sakit kepala, possibly cerebral venous thrombosis. And then lebam atau pendarahan means possible thrombocytopenia, sukar bernafas, sakit dada dan bengkak pada kaki. Sukar bernafas, sakit dada, most probably pulmonary embolism. Okay, so since the vaccination have started, of course, there are a lot of ED visits secondary to COVID-19 vaccination. So usually it ranges from 3 to 6 patients per day, and mostly are mild allergies or symptoms needing supportive treatment. So this was when the Pfizer vaccination start, as well as the Sinovac vaccination. So common side effects of vaccines, although it is a spectrum, some people did not develop anything at all. So it's from fever, malaise, injection site swelling, redness and pain, headaches, myalgia, arthralgia, nausea, vomiting, diarrhea, chills, lymphadenopathy. And apart from the allergies, usually it's all supportive treatment, IV hydration and analgesia and antipyretics. But with the vaccine-induced thrombosis, thrombocytopenia syndrome, TTS, there's a lot more that the emergency department has to do. Firstly, because the disease itself is very rare and the presentation is quite vague, and there's a need to do imaging and bloods to do with it. So there's a lot of fear as well among Malaysians. So therefore, we will see a lot of people who actually come, very young people saying that they've got the worst headache in their life, coming in not the first time, sometimes second and third time, doctor shopping, asking for a CT scan to be done because of the fear of the blood clots. So what exactly is TTS? I'm just going to say it as TTS right now because it's just too long. So it's actually a rare vaccine-induced condition in which patients develop thrombosis, which may be at multiple sites in one patient along with thrombocytopenia. So despite having blood clots, they are also bleeding. So it has been found to be linked with the AstraZeneca nCoV-19 vaccine. It's a recombinant chimpanzee adenoviral vector vaccine encoding the spike glycoprotein of SARS-CoV-2. So it's related with the AstraZeneca vaccine as well as the Johnson & Johnson vaccines, but we don't have the JJ vaccine here. So it mimics heparin-induced thrombocytopenia, but it does not have the same etiology as a thrombosis from disruption of Burkhouse triad that we have known. So not people who have pregnancy, not patients who have cancers, not people who are not ambulating, not people who are traveling. So these are implicating immune mediated. So it has been found to be related to the younger age groups and as well as the females. So based on current information, it is unknown if there are any pre-existing medical conditions that may contribute to developing TTS or make it worse if it occurs. However, people who have had history of developing cerebral venous thrombosis or splenic vein thrombosis or heparin-induced thrombocytopenia will not be allowed to receive the vaccine. Okay. It's not common. How common is TTS? Firstly, it's not common. It's preponderance for the younger age group as well as females. And from WHO Global Advisory Committee on Vaccine Safety, they have found that there's 182 cases of thromboembolic events, analysis of 190 million doses. However, we'll see the first dose of AstraZeneca COVID-19 vaccine without serious events can receive a second dose. And current data suggests the risk of TTS following a second dose is considerably lower than with a first dose. So data from the UK is slightly higher. The data from the UK suggests the risk is approximately 4 in and the rate in the EU is 1 per 100,000. So the UK Medicine and Healthcare Products Regulatory Agency has carried out its own review of 79 reported clotting events occurring in the UK up to 31st March. All occurred after first dose of vaccine, and during the same time of period, 20 million doses of AZ vaccine had been administered, suggesting that the overall risk of blood clots is approximately 4 in 1 million. Of these clots, 44 were CVSTs and 35 were clots in other major veins, all occurring with low blood platelets. And sadly, 19 of those affected died, 3 of whom were under the age of 30. So the risk is there. And how may it present? So evaluation for TTS is indicated if patients present with any of the symptoms below between 4 to 30 days of AstraZeneca vaccination. So it could be severe headache, visual changes, abdominal pain, nausea and vomiting, back pain, shortness of breath, leg pain or swelling, petechiae, easy bruising or bleeding. So it may cause cerebral venous sinus thrombosis, portal vein and splenic vein thrombosis, pulmonary embolism, arterial ischemia, adrenal infarction and hemorrhage, intracranial hemorrhage. So just to put a little perspective here, since I've been working in emergency medicine, so far, since I've been practicing in 2012, I have only seen 2 cases of cerebral venous sinus thrombosis in my life. So it is that rare. Pulmonary embolism, I do see quite frequently, but those are in people who has the risk factors to develop thrombosis secondary to the disruption of Werkhouse triad. So cancer patients, patients on oral contraceptive pills, obese patients, traveling patients. And intracranial hemorrhage quite on the daily basis, but not in the setting of thrombocytopenia. So since the start of AZ vaccination. So the AZ vaccination started around 3rd May. Around 20 patients have presented to the emergency department with symptoms that may represent TTS. So these 20 patients, I have excluded those that come with just fever or just swelling, just pain at injection site, things that that I don't have to think too much, and I can safely say that it's not TTS but rather just a common side effect of vaccines. Most common being headache followed by shortness of breath and blurring of visions. So these patients had their full blood count, their D-dimer, their fibrinogen taken as well as imaging. So this imaging, I'm talking about contrasted imaging, mostly CT, CTV, sometimes CTA as well, and CTPAs, and also ultrasound Doppler of the lower limb. Thankfully, I'm happy to report that none of them had platelets less than 150 and none of the imaging was positive or thrombosis. Although I must say quite a few had positive D-dimer and normal fibrinogen levels. So because TTS is something that is quite rare and quite new, so when we open up the guidelines, there are a few guidelines out there from the UK to our own Malaysian consensus guideline from the Hematology Society. So this TTS, there's less likely VITT, possible VITT, probable VITT. But the only confirmatory test is the PF4 ELISA assay, which is only done in Hospital Ampang. So if you can see on the left side, the green, less likely VITT if platelets is more than 150, in which I just state that all of our patients did. D-dimer less than 2,000 or less than 4 times upper limit normal range, normal fibrinogen, plus minus thrombosis on imaging, because you can also develop thrombosis, but it's not immune mediated. Then the possible VITT with platelets of less than 150, D-dimer of more than 2,000, low or normal fibrinogen, and no thrombosis on imaging. Then consider non-heparin prophylactic anticoagulant for Naproxen and send sample for confirmatory test. The probable VITT is platelets less than 150, elevated D-dimer, low or normal fibrinogen, and thrombosis and imaging. But the only difference here that there's the confirmatory test. So probable VITT, so once you confirm it, then it is VITT or TTS. So far, around 300,000 of AZ vaccination has been given. So if we are to follow the rate in the UK, we are bound to have our first TTS, but hopefully not. Hopefully not. Okay, so Malaysia is not known to have its first TTS case yet. And this is of yesterday. No TTS. Unfortunately, so far there has been 4,069 deaths secondary to COVID-19 in Malaysia, and the total confirmed case being a whopping 667,876 case, and then case active 70,112, and ICU cases nearing 1,922. So I'm saying that there's no case in emergency, but my title is the Emergency Medicine Perspective for TTS. So what is it I'm trying to say here? Okay, so just look at the pictures over here. So this is a picture of our emergency department on the daily. You can just go down there and you can see all of this. And unfortunately, half of this patient, and I'm not even kidding, are actually COVID or has um, been exposed to COVID. And they're all waiting for beds. And our ICU has gone tripled their bed, and we still don't have the beds there. So what I'm trying to tell is that definitely TTS is a devastating possibility. However, its incidence is very, very rare, and contracting COVID-19 is a far more harrowing possibility and a higher possibility as well. And I just want to put it up here that vaccines work, and vaccines protect against symptomatic COVID disease and reduce the possibility of transmission as well. And the best vaccine at this current moment is actually the one offered to you. And thankfully, I think most of us in the University Malaya and UMMC has been vaccinated. And emergency department will not have our guards down. We will continue to be vigilant to assess for the possibility of TTS among patients who have received the AstraZeneca vaccine. Okay, so let's begin again and rise up from this pandemic together. So this is the Pemulihan Negara that has been presented yesterday. So yeah, thank you.
Thank you, Dr. Nabeela, for the presentation. We actually have a few questions from the Q&A box. Let's discuss them. Thank you. From the first one would be from Dr. Ain Opan Ain Sabrina. Is VIIT exclusive for AstraZeneca vaccine only? What about other vaccines? What if the patient receiving other vaccine came with symptoms with the probable period? Do we investigate for VIIT as well?
Okay, so for Dr. Ain Sabrina, it's not exclusive for AstraZeneca vaccine. It's also related to the Johnson & Johnson vaccine. But in Malaysia, the JJ vaccine is not available. So both are viral vector vaccines. So what if patient receiving other vaccine came with symptoms? So let's say if the patient present with unilateral leg swelling or difficulty breathing with evidence of tachycardia and then type 1 respiratory failure, we will work out for possibility of thrombosis. And when we do work out for all these thrombosis, we will take our full blood count, we will take our coagulation profile, because for the usual thrombosis that develops because of disruption of flow, we need all of these investigations to confirm and also to manage the patient. So yeah, so we will still consider, but it's most probably not immune mediated. Can I just answer the second question from Prof SK Lim? Based on the experience from Europe on VITT, should we urge government to avoid giving the AZ vaccine to those aged less than 50 or less than 50? As far as I know, there have been 2 cases of VITT post-AZ vaccination. If we have alternative, why not reduce the risk on this age group? I agree with Prof Lim. And in fact, when I was reading about it in Australia, they have been advocating the younger age group to receive our Pfizer vaccine instead. But the problem in Malaysia, forgive me, I might not know the whole story. The problem is we don't have much in the first place. So right now, our phase 2 of vaccination, national vaccination is starting and is ongoing, and we have a lot of patients with comorbidities that have not received their vaccines. And the best for them is, of course, the one with the highest efficacy if it's available. So right now for Malaysia, we are giving preference to our more than 65-year-olds, those with comorbidities, those with to receive our Pfizer vaccine. I think that is a problem, but definitely I think we should advocate the AZ vaccines to be given to the older age group. And in fact, after this, the third rollout of the AZ vaccines will not be under opt-in anymore. It will be under PIC, which is the usual My Sejahtera way. Okay, anonymous attendee, patient with low platelets for reason e.g. ITP, how low should avoid AZ vaccine? Oops, I cannot read it anymore. Oh, any contraindications? Okay, okay, so as far as I know, from there are other options. The most contraindicated reason for contraindication for AZ vaccines is history of previous cerebral venous sinus thrombosis, panic vein thrombosis. Even people who have developed thrombosis in usual sites, in common sites, but provocated, are allowed to have AZ vaccines. But for ITP, I think is better to avoid it, especially because you don't know when your ITP will relapse. It's just asking for trouble. How high, Casno, how high was the D-dimers in the cases seen at the ED, which requires further imaging? And when the imagings were negative, but patients continue to experience their symptoms? Okay, so how high was the D-dimers? There's only one that actually was more than 2,000 and the CTPA was negative. Usually the ones that we have here was around between 400 to 800 or 6,000 to 1,000. It was actually in a range. And when the imagings were negative but patients continue to experience the symptoms, what do we do? Okay, to be honest, I meant to have further discussion with my family medicine colleague as well as our hematology colleague to see whether we can follow up this patient. But I do have cases, I think it's mostly related with anxiety. So this patient, for example, this patient that came during my call, she's 40 years old. It's actually her second attendee to the ED. She said she's got this headache that she had never experienced before. Pain score was 8 and she took my last stretcher in ED. So she insists on being seen and having a thrombosis to be ruled out. So we took her bloods, we did a CT scan on her, a CTV, and it was negative. And by the time the CT scan was done, her pain score was 0. So yeah, so to answer your question was, we all give TCAs to this patient to come back to see our family medicine colleague. If the symptoms continue. So this is in the settings where they don't have criteria for admission. So no type 1 respiratory failure, able to tolerate orally, socially, they have people around them that can bring them to the hospital. So as far as I know, they didn't come again, but maybe my family medicine colleague would know better. Okay. So I think the second question is almost the same. Is the follow-up really necessary? It is said that the possibility to develop VITT is up to 30 days. So yeah, if they're not symptomatic, I think maybe they're not so symptomatic anymore. I don't think they need to be followed up. Okay. Hi, Dr. Nabeela. Do we need to take all blood investigation as mentioned if patient presented with possible TTS? So, the main blood investigations, firstly, is the full blood count because we want to see the platelets, and then we also need to see the D-dimer if it's elevated and the fibrinogen. We do take those bloods. Yeah. How best is for the patients to be monitored? Is it with regular D-dimers? From Dr. Kasno, I don't really have an answer for that. I think the best person to answer would be our hematology colleague. Okay, thank you. Dr. Chan, Chan Hen Cheng. 23 countries have suspended AZ vaccines, including Japan. Comment. Indonesia, 20-year-old man died of CVST recently. Query comment. How many virus adjuvant preservative in AZ vaccine? Okay. So the preservative or stabilizer in AZ vaccine is polysorbate. To be honest, data from the Indonesian, I don't mean to like ignore your question, but I would query the information from Indonesia unless it is in a scientific paper, because there's just a lot of scaremongering over there, and it has spilled to our Malaysians elderly population, and it's just so devastating. So I think I wouldn't want to answer that. Okay. How do we monitor here? Is there any?
I think Dr. Nabeela will have probably one more last question because it's
Okay.
already 8:29.
Okay.
So we will answer from Mr. Ng Wei Lee. Do you think full blood count alone is adequate for assessment for VIIT in an outpatient or ED setting after considering the clinical circumstances?
Okay. So interesting. So whenever I look at the guideline, mostly from our hematology colleague, but there is one guideline from the, emergency physician, Royal College of Emergency Physician in the UK. So what it says is, the first is to consider whether the patient, one, has just received the AZ vaccine between 4 to 30 days. And then two, is there a possibility of the presentation, meaning the shortness of breath or the headache being secondary to TTS. And then number three, to proceed with a full blood count. So if the full blood count is more than 150, then the patient had no other worrying symptoms. For example, the headache, it was resolved with pain relief, simple pain relief. There's no neurology, there's no associated visual disturbance. Then discharge with reassurance. But if the patients have other disturbing problem, for example, visual disturbances, or maybe vomiting worse in the morning, then follow up needs to be done. For example, a CT scan, but to consider other things that can that can cause the headache, and not just basically not to discharge them. Sure, it's not TTS, but to address their symptoms as a possible presentation of other disease entities. Yeah, does that answer your question? Maybe.
All right. I think it has come to an end of this first session for today. So many questions. I think we will try to answer them. We'll type out the answers.
Yeah.
Yeah. Thank you so much, Dr. Nabeela, for sharing with us the information about this VIIT. I hope everyone in Malaysia can get vaccinated as soon as possible. Kita jaga kita, and we can all do our part to fight this pandemic together. Thank you so much.